Hi, this is Brian Kim. I want to share with you case number 208 in the best way to do cataract surgery series. This is a dense cataract with a small pupil, and I'm going to share with you how to master placing the chopper and phaco tip within the bag for lens disassembly. Oftentimes I have folks telling me it's just a bad idea to do cataract surgery in a small pupil. I would rather put hooks or rings or whatever. They feel like it's dangerous. Well, it's dangerous for you, but it's not dangerous to me. And so you have to really kind of redirect and orient your expectations and perspective based upon the surgeon who's doing the surgery, not based upon how you do the surgery, right? So it's no different from if you're a race car driver. The things that you would do would be different from if you're not a race car driver. And of course, if you're not a race car driver, there are certain things you would do with a car that you feel would be very dangerous, but for a race car driver, it wouldn't be. And so it's a similar analogy. But in my mind, in my experience, I have very little worry or risk of causing any problems because I do it this way thousands and thousands of times. And I'm not exaggerating when I say I have never had a complication because I did cataract surgery in a small pupil. And so you saw I put some intracameral epinephrine and then dispersive viscoelastic. I made my incisions, of course, and did the corneal mark. And now this is the microforceps, the Morio microforceps. Puncture the center, pull down towards me, grabbing the right side of the tear, going around circumferentially. I have my cannula there to push more viscoelastic if I need to. You can see this pupil is distorted. There's probably an element of floppy iris on this case. Again, I did put in epinephrine at the very beginning. But none of this is going to scare me because I know what I'm doing with the instruments and I have complete control of my instruments during the entire case. And I know where the capsule is. I know where the anterior capsule is. I know where the lens is. And I know exactly what I'm doing when I'm disassembling the lens. So this is the capsular fornix hydrodissection technique. I place the cannula under the rexus edge contra-incisionally. Make sure I'm in the capsular bag, point the tip down, get a nice wave. And I'm being mindful of the iris, making sure I don't push too aggressively with the fluid because I don't want iris prolapse. I lift the lens up a little bit, sweeping on the left side, decompressing some more, and then sweeping on the right side. Very gently sweeping and rotating the lens. And the lens begins to spin. So again, this is a rather dense lens. Some people might say, put hooks in, put rings in. But you know, again, anytime you do more manipulation, there's always potential for complications. There are always videos and cases of people causing serious damage using a ring. And so that is really not the panacea. It might be the panacea for you if you can't do the surgery without it, but it's certainly not for me. So place the chopper under the rexus edge contra-incisionally, the phaco tip vertically sub-incisionally, fracturing the lens completely in half. That is the double chop. Turning my chopper sideways, making sure I'm underneath the rexus edge, hooking the right heminucleus from the periphery, turning the chopper vertical, pulling it centrally toward the phaco tip, fracturing the right heminucleus in half, and that is the cross-chop maneuver. The lens piece is not quite sure what happened there, but I went ahead and just performed another cross-chop maneuver and then fractured that left side heminucleus. I think what happened was it had an asymmetric chop, and so the right heminucleus was rather small and it just gobbled up fairly quickly, and the left side heminucleus was much bigger piece. I think it didn't chop straight down, it kind of chopped an oblique shelf, and so that left heminucleus was much bigger. So place the chopper around the lens, hooking the peripheral lens and crushing it against the phaco tip with another cross chop maneuver, and then using successive crushing forces to crush the lens into smaller and smaller pieces, and then emulsifying the lens piece. You will notice I will only activate ultrasonic energy and vacuum when the phaco tip is in the central safe zone. When I'm using the phaco tip to chop the lens pieces, I am not using ultrasonic energy or vacuum. And so therefore, the phaco tip has a dual function. It's in its normal function to eat up the pieces, but you see the way I'm doing it differently from how we were taught. I'm using the phaco tip as a chopping instrument. That is that secondary dual function, and that's why I call that double chop. And that's why I call it mechanical fracturing, because I'm using the instruments to crush the lens pieces. I'm not using the phaco tip to hold the lens in order to chop it, because that's a really different function. That's really how they do it for horizontal chop and vertical chop. That's the traditional way of using the phaco tip, to hold the lens with vacuum. But again, I'm using the phaco tip as a chopper, which is a very different way to think of it. And this is the way I've originated it since 2016 when I started doing these techniques. So I go ahead and very carefully remove the epinuchal material, making sure that the chopper is deep to protect the posterior capsule. There's a little piece that's wedged into the incision there. I'm just trying to carefully eat that up. If I see it, I want to get rid of it. You don't want those pieces flying underneath the iris, and then you have a surprise post-op day 1 or post-op week 1. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. You remove the cortical material at that incision. Remove the cortical material from anterior to posterior, peeling from anterior to posterior, which allows you to clean the cortex in a much more clean fashion. Always start subincisional, because that's the easiest part to remove in the very beginning, because the capsule is being kept in a concave orientation. Once you start removing the cortex, the bag starts to collapse, the posterior capsule starts coming towards you, and that's not when you want to go after the subincisional material. You're going to actually grab the posterior capsule versus grabbing the cortex. Polishing under the rhexis edge, polishing the posterior capsule as well. This is a fairly clean bag. Again, small pupil. The polish mode is excellent, and the polymer tip is excellent for this case, because I can confidently sweep blindly, even though I can't see the capsule, with these instruments. Disengage the infusion and pushing cohesive viscoelastic to fill the bag. And I'm just going to do some limited sweeping, not too much because I can't really see there. And then I go in with a single piece acrylic lens going into the capsular bag. I turn the eye away from me so I can see the contralateral rhexis edge. And that's why I turn the eye. And by doing it that way, I know that the lens is going into the bag, at least the distal side, the contralateral side. And then I go in, activate irrigation, and make sure the trailing haptic goes into the bag, rotating the lens, tilting it, getting underneath the lens, removing all the viscoelastic from within the bag. Polishing underneath the rhexis edge. Removing all the viscoelastic from the anterior chamber. And then I'll hydrate my incision. So in this case, I'm confident that both haptics are in the bag. I'm not going to use a Maltzman to look, because as I tilt and rotate it, I'm very confident that it's in. Make sure you decompress before you come out. You don't want iris to come out of the wound. And then I'll hydrate my incision. So again, fairly dense lens, not terribly dense, probably like a 2+. Again, small pupil. I know exactly where my instruments are. I'm within the bag. I don't really need to make the pupil huge. You can cause iris root damage as you try to pull the rings out. Again, you're having hardware in the eye. Yes, if you need it and your technique requires it, of course you need to use those devices. But that means that you need to question your technique. Again, if you don't want to change it, that's perfectly fine with you. But if you're the type of person that wants to push yourself and continue to improve your techniques, then I think you should think about performing surgery the way I do it. Why? Because I feel very confident every time I go into the surgery that I know that I can safely execute the surgery and nothing is going to happen where I feel like I can't get myself out of trouble. And I think that's very important because I remember seeing some surgeons, they go into surgery and they're very anxious. They're very anxious from the get-go, even before they've scrubbed. And that's really, for me, a very stressful place to be. I don't want to be that surgeon who's constantly anxious every time I walk into the operating room. I want to be extremely confident every time I go in. And you know what? Truth is, the patient deserves that, and I should be able to deliver that. And so when I go into surgery, because I do surgery like this, on small pupils, big pupils, weak zonules, whatever that is, I can execute the surgery because I know I can hook the peripheral lens and get it out of the bag. If I rely on vacuum to grab the lens pieces and then they start falling apart, you get that bowl out phenomenon, and then now you have nothing to grab, because if you grab and all you have is this thin shell, right underneath it is a posterior capsule. That is really poor technique. If you need vacuum to hold lens pieces and bring it up, then you're going to be in big trouble. And then you might end up creating a hole in the posterior capsule. If you learn how to hook the peripheral lens like I do, you can have a big pupil, small pupil. It doesn't really matter. You can successfully and confidently and safely and easily disassemble the lens in a wide variety of circumstances. And in my mind, if you do it this way, you can conquer any clinical surgical situation. And the truth is, don't you want to be the best version of yourself, not only for yourself, but for your patient? So I hope this was helpful to you, and I thank you for your attention.